So what we're seeing here is a right Achilles insertional tendinopathy. The protocol that I'll be showing is really doesn't matter whether it's insertional or mid-portion. What we're really trying to do here is just make sure that we're targeting the whole Achilles tendon, its insertion, and the mid-portion as well. Now you can see that there is a little bit of extra fluid around that sort of area where I'm palpating at the moment, and so we really are trying to break up and desensitize this whole area. Now there are a few areas that I'm palpating and finding pain from. One at that sort of insertion around sort of that Hagelins or pump bump. But really the protocol, although this one may include that, is typically pretty consistent. And for a lot of these spots, the patient isn't actually tender. And I'll start marking those now where I'm like, okay, well, these are the areas that I want to get and want to inject based on my knowledge of anatomy and sort of where these points are, the Valix points that we're trying to target. Now, they are very much, on the posterior aspect. They're not sort of, on the side or medial or lateral to the Achilles tendon. They're areas that, I'm wanting to be sort of, maybe that posterior medial or posterior lateral, but still really on that posterior aspect. If you're finding that is, the injection points are a little bit more deep, to that sort of anterior aspect of the Achilles tendon, then you might have sort of gone over to the side too much. And, particularly in our leaner patients, we do want to be very mindful of this. We want the dextrose, in this case, to be very much on that posterior and superficial aspect. Now, of course, as always, we are going to be wiping over with our alcohol wipe or otherwise, maybe chlorhexidine. Let that dry a little bit and then undertaking our injection. Again, I'm wanting to go perpendicular to the skin where we're injecting. Of course, injecting before we're entering the skin to remove any sort of neurovascular bundles that might be there, so we're less likely to traumatize them, and then putting about our 1/2 mil. Now, very commonly, and particularly, I think it's going to be on the third spot here, it's quite a tender area, particularly these inferior aspects. Patients are going to have a little bit of a jump, and so, having that hand to secure is a really good idea. Also consider whether you want to just have your pinky sort of, leaning onto the patient, just for a little bit of extra support there, to make sure that you're comfortable, the patient's comfortable, and you're not necessarily shaking or moving too much there. One of the other things that I do quite commonly is I keep my elbow in very close to my side, which again is going to reduce that sway that I might be having. Now, this is the point that I'm sort of saying, it is quite tender. This is where sort of a lot of our patients would have that maximal pain. And you can see that I'm putting a little bit more than 1/2 mil in there, just in case I can't get back there because the patient might be a little bit too sensitive in that area. But we can see that there's some really nice plebs going in there. That there's a lot of that white tissue because of the pressure that we've provided with that fluid that has already gone in around the Achilles. Again, you can see that I'm sort of positioning, reasonably superficial, but there's some aspects there that I am going a little bit deeper. And of course, being sharps aware, maybe not necessarily best practice, but very difficult with multiple syringes. Definitely just be aware, what you're doing that way. Again, myself having a fair bit of experience with this, I'm quite comfortable around needles, but just making sure that you're really careful there. Now, because some of these higher points might be cut off a little bit, and my apologies for that, but I did feel this was a really nice video to have undertaken as well. And we can see that some of these higher spots, we really do want to get that 2 or 3 levels above where our pain's coming from. There may be sometimes some further medial or lateral aspects that need to be targeted of the gastrocsoleus. Now, what you're seeing here is that I'm really trying to mobilize that Achilles tendon, load it, and really, I can do that even for about 30 seconds or so. Now, more commonly when we're undertaking this protocol, patients are not tender at all of these spots. And so quite commonly I am undertaking 2 injections straight up. Very commonly the first injection is not going to resolve where they do have any pain. And so what I'd recommend is doing straight up 2 sessions and then seeing how they're feeling at all of these spots. You know, sometimes you can do the third. I definitely find that just doing that second, you know, straight up, we're not necessarily testing those Valix points for further pain. We're just undertaking the injections, knowing that we're comfortable in our protocol and approach to what we're looking at here. Again, you can really see that blanching of the skin there, you know, that white tissue, you know, because of all the fluid and pressure we're putting in there, pushing away sort of that superficial blood flow. Again, you know, a very tender point here. Some patients may only be able to, you know, be comfortable undertaking one course. And so sometimes I will just leave it at one course, and it doesn't necessarily reduce the effectiveness. But, you know, where we can do that second or even up to that third for the tender points, I think that's of huge value for our patients' longer term outcome. And you can see that I might be going a little bit deeper sometimes. Swapping over those syringes, and you can see I've got a little bit of fluid in there. I'm not going to just put, you know, 0.4 of a mil in. I'm going to be really carefully making sure that I do, you know, provide the patient a therapeutic dose as such, to ensure that we do get a good outcome for what we're looking at. Again, my apologies for a little bit of it cut off, but you know, you can even see those lower areas that are still blanching and still in a really good position there, so that we know that we are getting the outcome that we're wanting to with regards to that infiltration and into the right tissue layer as well, which is such an important aspect. Sometimes in between, I'll even feel a little bit further around and sometimes identify, you know, another Valix point that we're wanting to look at, in this case, a little bit higher on that gastroc. And so, you know, providing a further injection into that area. Again, post-injection, I'm typically wiping over. I'm going to mobilize it again, but then in the end, you know, really giving that patient some time to sort of recover. If I'm happy, you know, like always, I'm going to put a bit of Hyperfix on. And I really like this approach for all of my Achilles patients. It's something that I do even just on my initial consult as I'm going through their options, because most people do find that this is going to reduce their pain immediately. Also make sure that the patient isn't in a plantar flex position. We really want to make sure that they're going to be comfortable once they finish that as well.